So Sagar, I want to get back because this standard though, could it be a decade old? Is it, I mean, despite all these changes? So in a way, all the changes that are happening have happened in, if I think about, they always talk about like the history of the universe, the time of the universe, and we're in like the last second of the 24-hour clock. If we think about like the last, the human era. And we think about myeloma, I feel that same way. Everything that's happened has happened in the last second of that clock. Yep. And it's happening so fast. So if you could just kind of quickly overview that, we found this really good sweet spot. You're seeing patients surviving 10 or more years with the standard of RVD, transplant, maintenance, LEN, and then all of a sudden, kind of everything broke loose.
Yeah, no, I think you're raising a really important point, and it actually gives me a chance to sort of plug a paper we published in JCO just a couple months ago, which was 1,000 newly diagnosed myeloma patients who all got RVD, single transplant, and then risk-adapted maintenance. And just as you described, the median overall survival for the entire group is 126 months. And then if you look at the standard risk group by genetics, it's even much longer than that. So you're right, we have a good platform, but it's not working for absolutely everybody. And so the question is, how do we bring up those people that are on the bottom part of that curve? And I think the addition of drugs like daratumumab to the induction therapy regimen is, I think, a big step forward for transplant eligible patients. And in fact, that's now become our standard for the standard risk patients. And for the older, frailer patient, we're getting away from MP-based regimens. That happened in the last few years. But now the question is, if RD or Len-Dex is the standard, when you add Dara to it, it gets even that much better. So I think antibodies are really changing the current paradigm of treatment.
All right, so antibodies may be changing, but it remains a disease that has a combination therapy approach in which the drugs that are available are being administered by different routes of administration. And Correct. Could be sub-Q, IV, and oral, but we don't have an oral-only regimen, and it's not an IV-only regimen. And so it's important because one of the things we want to get into today are the complexities related to that. Do you see that changing with these new agents that we're going to get into in all IV? And I think about the parallels where, are we going to have all IO-based treatment of non-small cell lung or other, and there's not going to be a chemo plus? Do you see that changing, or do you see that these new agents will be additive and we'll be getting into an alternative triplet or the new quadruplet, but this complexity of the administration is going to remain?
Yeah, I mean, my sense is that the complexity is going to remain. I think right now, for instance, a minor tweak that has occurred in the last few months has been switching from daratumumab IV to sub-Q. Bortezomib switching from IV to sub-Q was a tweak about 10 years ago, but I don't think we're going to get it with an all oral or an all IV approach across the board.
And with those sub-Q administrations, they would still not be patient self-administered sub-Q. They would still be administered in a healthcare setting. That's correct.
That's correct.
So Ray and Stacy, because of this movement towards sub-Q, and it's not just restricted to the couple agents that were mentioned, rituximab now has a sub-Q. Are you seeing it in your practice environments, and specifically, and we'll address this in more depth later with the COVID impact on care, but are you doing any advanced cancer therapy that is sub-Q, self-administered at home, or are those patients still coming in? Stacy?
Our patients are still coming in. We've not adapted any home care.
And Ray?
Yeah, all of our patients are coming in to be treated even for sub-Qs. I would interject here, though, that there is a payer push now for home care. So, that's probably a topic for another day, but we do see some of those pressures. And I know, Stacy, you've had probably more than we have, but yeah, there are some payers that are looking now, especially with COVID, and saying, hey, why can't a home health nurse give sub-Qs at home? So it's a concern for us for sure.